Hello everyone, this is Chadi Alraies from Heart Trending. Today is day one from TCT 2020, and if you were there or not, but there is a lot of science we need to cover and late breaking trials. Phenomenal science that presented, I think, going to be a game changer. With that, let's quickly dive in, so don't waste any time. So again, this is TCT day one, and I'm going to go over each trial that was presented. At the same time, also we'll go over some of the highlights for tomorrow, day two, which also is not short from today from being busy. So with that, as I said, this is TCT day one wrap up. Okay. So just to highlight a few things, as you know, TCT MD has been having a quick, phenomenal coverage. It's happening as every trial presented. These highlights coming from journalist Shelley Wood and her team, who's doing a phenomenal job, which is, I think, it's a very quick way to understand and know exactly what these trials are, what the phenomenal access to presentation. If you are not a member, you still have an access to the TCT TCT MD PDF, but if you're a member, you get PowerPoint access as well. All right, with that, let's start with the first trial, which is Prospect trial. This is a trial I mentioned yesterday. It's related to natural history of using IVUS imaging in patients with acute myocardial infarction. Again, these patients already had an event, but the non-culprit vessel and these patients were evaluated with IVUS and NURSE as well. Again, original treated culprit lesions, scaffold randomized treated lesions, and untreated non-culprit lesions as well. So again, these patients who had angiographically non-obstructive lesion with IVUS plaque burden more than 65%, randomized to treatment with BVS plus guideline medical therapy or GDMT, or patients received GDMT alone. Again, when we follow this patient over the course of the follow-up, there was 14.4 event or major cardiac event, which is the primary endpoint of the trial. 4.6 happened in the culprit lesion, but 8% happened in the non-culprit lesion, which is really significant and speaks to the fact that these patients really have a lipid-rich, angiographically non-flow limiting plaque. However, this is prone to rupture. And this has led to the prophylactic treatment of these high-risk plaque to the Prospect Absorb trial that was presented by Dr. Greg Stone. Phenomenal study, great design, and I think a game changer, and also a call for larger randomized trial. As I mentioned yesterday, this is examine whether treatment of vulnerable plaque with Absorb BVS plus GDMT safely increased the MLA at 24 months compared to GDMT. These are patients who had a negative FFR or IFR with a lesion less than 70%, but these patients had an IVUS and a plaque burden more than 65% on IVUS. These patients, again, randomized to either receiving GDMT and Absorb BVS, as you see there, the small number, 93 patients, and GDMT alone were 89. Randomized lesion retreated MACE were 10.3% in the GDMT alone, but its reduction in Absorb BVS. However, this is was not statistically significant due to the small number of the patient. But again, this is a proof of concept, and maybe these lesions are underestimated, especially in patients with severe, with non-severe, non-flow limiting, physiologically negative lesions. Moving along on the same note, these are the patients who have, again, we spoke about it yesterday, and these are the patients who had negative IFR or FFR specifically, but they underwent OCT. This is what's called combined OCT FFR. Let's see what they found. Again, in this trial, these patients were randomized to, this patient had an acute coronary syndrome, but the non-culprit lesion were morphologically modified or evaluated by OCT and FFR. Again, these are negative FFR, but positive, what's called TICFA or thin cap fibroatheroma. Just to give you a perspective before, as you see here on the right side, diabetic patients specifically with TICFA has the highest MACE events at the end of follow-up of 3 years. These are very significant, very vulnerable plaques, especially in diabetic. And this was the focus of the trial here. As you see here, the patients who underwent unstable diabetic for sure, keep that in mind, and had one or more culprit lesion that is evaluated by FFR, mild to moderate lesion. If it is less than 0.8, no-brainer, these patients received revascularization and OMT. And patients who are more than 0.8, they were randomized either not randomized, they were evaluated with OCT. They either had TICFA or did not have TICFA, and therefore managed either with therapy or without therapy. Again, you see the number here, are completely normal, OCT with TICFA, and then no TICFA, 97% in the area in the group of interest, and 291 in those who did not have TICFA, diabetic but no TICFA. As you see here at end of follow-up, days of follow-up. Again, this is a long period of follow-up, but you have to pay attention to the number here as well. 44 at the end of follow-up, and the no TICFA was 144. But the line separates pretty early with a p-value that's significant, indicating that these patients who are diabetic and have a TICFA positive are vulnerable for plaque rupture, and therefore OCT can improve the accuracy of high-risk lesion and patient identification, and should be therefore be embraced. Again, this is a combination between patients who received diabetic, negative IFR, physiologically not significant, but they have TICFA on OCT, which is a thin cap. These patients did not do well on follow-up. Moving along to the next study, which is we are delightfully part of, led by Dr. Tim Henry from Christ Hospital and a group at the Minneapolis Heart Institution, NACMI trial, which is a NACMI North American COVID positive ST elevation myocardial infarction. Very interesting study. It's a registry again. The highlight or the background that Dr. Tim Henry presented was that there is a 15 to 28% of COVID positive patients admitted with elevated troponin. 28 to 49, there was 45%. There was a reduction in STEMI, and we published about this using a Michigan cath lab database. 46% was a reduction during March and April 2020 compared to March and April 2019. So the goal here was to create a consortium, create an understanding of how these patients are treated, and also data-driven treatment plans. As you know, these are the three pathways that the patient were kind of put into. Patient 1 suspected COVID or PUI with COVID-19, and they did have indeed coronary artery disease and ACS and underwent successful PCI, but COVID was ruled out within 24 hours. Patient 2, COVID positive and diagnosis of non-myocardial MI and no fibrolysis and no coronary angiogram. And the group 3, which is the COVID positive and ST elevation treated with fibrolytic or PCI. Again, these are the two groups, either STEMI or new left bundle branch block, divided into two groups, confirmed 2000 with the COVID-19 and PUI, and they were propensity matched for the historical cohort of patients from the Midwest STEMI consortium. These are the sites, as you see there. I mean, we are really delighted to be part of this study to help a lot of patients with COVID-19, as this pandemic did not stop yet. Few highlights of this trial or the registry: African American, Hispanic has the highest presence of STEMI compared to other ethnicity, and also diabetic. So being diabetic, African American or Hispanic has the highest risk for ST elevation myocardial infarction, and these patients also had lower ejection fraction and a higher likelihood for presenting with cardiogenic shock with atypical symptoms, as you see there, dyspnea being the main presentation in these patients. Again, the outcome as shown here in orange, COVID positive has the worst outcome compared to propensity matched cohort. So again, this is a registry that's going to be generating a lot of data how to treat these patients, how to triage them, and how to give the patient best options ever by protecting the staff and the patient from getting worse. Moving along to the next trial is Compare Crush. This is a quick trial presented from Netherlands and designed a very nice design focusing on prasugrel and patient presented with STEMI given crushed versus integral tablets in the EMS before the patient arrived to the hospital for primary PCI. These patients in 300 plus patients in each arm, and these patients were intention to treat analyses. As you see there, the primary endpoint in terms of TB3 flow and infarction related artery. At first angiography, there's no difference between the two groups, and also complete ST elevation resolution. There's no difference between each group. However, platelet reactivity at the beginning of primary PCI was lower in the crushed group compared to the integral group, which means that the prasugrel does work faster if you crush it, but again, at the same time, did not change the clinical outcome or the ST elevation resolution. Moving along to the next trial, which is TICO-STEMI. And here I would like just to highlight a couple of things. TICO was presented at ACC 2020, and it presented all cohort of patients. There were almost 33% cohort presented with STEMI, 33 with NSTEMI, and 33 plus with unstable angina. So this is presented and showed that at 3 months, ticagrelor, dual antiplatelet therapy for 3 months, and after that, continue with monotherapy with ticagrelor alone compared to DAPT, did not show any difference in terms of thrombosis or stent thrombosis or any adverse cardiac event. However, it was associated with lower bleeding compared to dual antiplatelet therapy. In this analysis at TCT, they focus on the STEMI cohort of patients only. So let's see what they found in this trial. So again, this is a Korean-based study. Dr. Kim presented this study. Again, this is a design just to make you familiar with it. These patients were randomized to ticagrelor monotherapy after 3 months of DAPT versus 12 months straight with DAPT. Again, intention to treat, NACE as treated, and landmark analysis, all showing lower events in ticagrelor-based monotherapy at 3 months after 3 months of DAPT. Similarly, major bleeding was completely lower and significantly lower compared to DAPT. And this tells you to the fact that maybe ticagrelor monotherapy, and especially in ultra-thin bioresorbable polymer sirolimus eluting stents. Pay attention to that, please. It's a bioresorbable ultra-thin polymer sirolimus eluting stent. 3 months of DAPT and then continuing with ticagrelor only. Similar to the Twilight finding almost, it's beneficial and does not cause more bleeding. So with that, I mean, let's go move on. I mean, this is phenomenal studies. There's other science presented. There was a lot of pavilion happening at the same time, high-risk PCI, imaging, structural didactic session as well, which they think make TCT kind of well prepared for the virtual compared to the other conferences, which is, I felt this is really a big gap in didactic, and this is what I'm really advocating for in terms of didactics we missed from these conferences beside the late-breaking trials of the great science that we see every time. So with that, let's see on what's happening tomorrow. Few landmark studies, again, late-breaking trials starting tomorrow at 11 o'clock a.m. Eastern Time, moderated by Dr. Bono and Dr. Marty Leon. This is valvular heart disease. It's completely structural tomorrow. Scope 2, a randomized trial of 2 self-expanding TAVR bioprostheses. This is comparing the accurate valve with the core valve. Scope 1 was presented before. This is a Scope 2 trial, longer follow-up. We'll see if there's any difference. Reflect 2 is presented by Dr. Jeff Moses, randomized trial of cerebral embolic protection devices during TAVR. Exciting, and this is showing a 9 French device, 9 French in the femoral sheath, in the femoral artery, and showing any protection for any clinically significant drop in the clinically significant neurological deficits. And MITRAS is a randomized trial for ASD closure after TMVR. This is the iatrogenic ASD that was created after TMVR, either clip or valve replacement. and if there is any significance. And I think the outcome was 6 minute walk and shortness of breath, which is a very soft outcome, but again, it's still significant. We'll see if that add any more. But again, keeping in mind hospital cost, device, and procedure duration, maybe it's affected during closure of these ASD devices. The second late breaking trial will start at 12:30 p.m. Eastern Time. Will be a complex PCI strategy modeled by Ziad Ali and George Dengis. The first one, which is I think I am looking the most for during TCT 2020, is Disrupts CAD 3. As you know, there was CAD 1 and CAD 2. It's international, mainly European. It's got a CE mark based on that. But the CAD 3 is the IFU trial. It's based mainly in the US. Dr. Kriakis is the primary investigator, showing the safety and efficacy of intravascular lithotripsy or shockwave for treatment of severe coronary calcification. This is going to be the largest cohort of patients. I will go over the numbers in a minute with you. Second one is Science 1928, assessment of 3 months and 1 month depth after everolimus stent in high-risk bleeding risk. Again, Dr. Roxana Meran presenting that. It's going to be complementing Twilight, complementing Leaders Free, complementing TICO as well, that we just talked about. Defined PCI, as you know, defined PCI, this is a patient who were deferred from IFR, and we'll see post PCI residual ischemia if the pressure wire will continue to show any residual ischemia, and if treating this residual ischemia will have any benefit. Finally, ultimate, we are every major meeting we get more follow-up emphasizing on the importance of IVAS guided versus angiographic guided DAES, and this is a call for just to continue to do more IVAS pre and post. Doing it pre help you evaluate the burden of the lesion, help you prepare for the lesion if it's calcified versus not calcified, tortuosity, bifurcation, takeoff, good landing zone, and also post therapy with IVAS, and which is help you for stent apposition if we left any plaque uncovered or if we have any dissection remaining. Just want to go back slightly, a few words about Disrupt SCAD 3. This is going to be the largest shockwave or lithotripsy trial. It's going to be designed for assess safety and efficacy of the shockwave medical coronary lithotripsy system. The goal was based on the Orbit 2 design in terms of performance goal, and which is for orbital atherectomy, and primary safety endpoint at 30 days and MACE rate, dissections, perforations, as we know, and we learn from CAD 1 and CAD 2 is very low, and primary effectiveness endpoint less than 50%. The goal was to go for 400, but I think they reached 380, 390. We'll know exactly tomorrow. And sub-study of OCT, pacemaker, ICD, and follow-up residual 30 days. And this is, again, mainly in the US, but has international sites. And we'll see if what's the findings tomorrow. And exciting study that I'm looking for. Again, I would like to bring your attention to other World Connect and e-satellite events. Phenomenal controversy in STEMI management, controversy in CTO, management of high bleeding risk patients. This is all daily questions that we encounter in the cath lab and the patient we treat in the cath lab. So please, if you have time, and again, the beauty of TCT Connect this time is all saved and you can access it at any time. Innovation and e-training, Dr. Marty Leon and Dr. Stone put together a phenomenal program, and Juan spoke about it on the opening remarks today, how he moved the training pavilion to be virtual and how to continue that initiative that started 3 years ago. Phenomenal session. Don't miss that as well. Again, I would like to put the plug again and thank you to TCT MD for providing me with all these slides. Again, I did not have the, I wouldn't have be able to prepare this presentation without the access to these slides on TCT MD. And then the phenomenal coverage news by Shirley Wood and her team, Mike, Todd, and team. Phenomenal work. Thank you so much for all you do. Again, you can watch this video and others on Heart Trending with Chadi Alraies MD on YouTube channel. I'm going to post this one, and also every day I will do a daily wrap-up. We'll cover the sessions for today and also for every day, and also give you a heads up for what to expect for the next day. Thank you so much for watching. This is Chadi Alraies from heartrending. If you have any question, please leave it in the description below, or if you have any comments. If you think I can do a better job in doing these videos, please do let me know. If you don't hear me very well, I need to get a better mic, or if you have any questions related to where I get this material, or if you would like even to be part of NACMI registry. Dr. Tim Henry is really excited to include more sites on COVID-19. Please drop us a note or email me directly. Thank you so much for watching. This is Chadi Alraies, and this is TCT 2020 Day 1 wrap-up. Thank you so much.